Well, so thank you all for being here. Thank you for being to Sunfest at all, to coming out to Sunfest, and for coming to this panel as well. We're going to be talking about artificial intelligence and healthcare. And this is something that I got interested in, obviously seeing a lot of the explosion in news around ChatGPT and some of the other artificial intelligence models that were coming out, and really wondering how this was going to intersect with the work I do. So my name's John Ingold. I cover healthcare for the Colorado Sun. That means I write about everything from infectious disease to health policy. I write a lot about health insurance. I write a lot about what they're doing at the state capitol. I also cover how healthcare gets practiced, including at some of our major health systems. And so really am excited to put this panel together. I think we have three really fascinating panelists, really smart folks, and folks who have a real diversity of knowledge here. So I'm pretty sure there's not a question you're going to be able to stump them on. We'll test that later, but I'm pretty sure you won't be able to do it. So just to introduce our panelists, to my left immediately, we have Dr. Casey Greene. Dr. Greene is the director of the Center for Health AI at the CU Anschutz Medical Campus. He's sort of a recent snag for us here in Colorado. We persuaded him to come here from the University of Pennsylvania, and I think he's you run a lab, you teach at the university. Yeah. At some point you sleep, right? Occasionally, yeah. So we're really excited to have him. We have next is Dr. C.T. Lin. Dr. Lin is the Chief Medical Information Officer for UC Health. What that means is that he handles a lot of the tech data sides of healthcare and health management. I'll let him explain more because I'm going to bungle it. But health medical records, electronic health medical records, and it also means that he oversees the implementation of UC Health's artificial intelligence work. And then last but not least, we have Dr. Matthew DeCamp, who is an associate professor at the Center for Bioethics and Humanities on the CU Anschutz Medical Campus. That means he is somebody who thinks very deeply about the ethics of healthcare stuff, and especially he's been thinking a lot and doing a lot of research on artificial intelligence. And Dr. DeCamp and Dr. Lin are also practicing physicians as well. So they see patients and can look at that weird mole on your back later if they need to. So I thought I was being smart when I came up with this panel idea. And I was like, oh, we're going to talk about AI and healthcare. And so I called Dr. Greene, and Dr. Greene said, well, we have to define what AI is first, which is like one of those dumb questions that's actually really smart. So I'm going to let you tackle that. How would we go about defining AI for our purposes here?
Yeah, so I think there are quite a lot of different ways you could define AI. I think for the purpose of this panel, probably given the excitement and interest around ChatGPT, I would sort of think of it as methods. So there's a subset of AI called machine learning, and this is essentially where we try to teach computers to do stuff by showing them what we want them to do. And so I think, for the purposes of this panel, thinking about AI in healthcare and where it is now, I think that's the scope of the definition that I would use. So essentially, cases where we are training computers to carry out some task through data. There's an entire other set of, there's a few other subfields of AI that sort of this doesn't get incorporated in, but if we go that broad, we'll never actually talk about anything exciting. So that's kind of where I'd start.
Is there like a basic overview you can give on how it works? Like how does it get the information that it uses to spit back out at you?
Yeah, so I think, if we talk about large language models, so how many folks in the audience have used ChatGPT? 2, 3, okay, some. How many have heard of ChatGPT? Okay, everyone. Okay, good. So the way that these models are initially trained, right? I just said we want to train a computer to carry out some task. So the first step in training a large language model like this is we say, hey model, can you fill in the, what word might come next?
This is not an AI model here.
Blank. Yes, exactly. So it's like fill in the blank, right? Can you predict what comes next? So then you're essentially training a model to be that annoying person in a conversation who won't stop finishing your sentences. That's what we're trying to do, right? We give it part of the sentence and we're like, predict what comes next. And so essentially we do that with enormous amounts of data from the internet. So essentially Washington Post stories, New York Times stories, right? Kind of news, Colorado Sun stories.
Sun stories, yes.
Know your audience.
I have some concerns about that, but okay.
Also a lot of these are trained with a lot of content from Reddit, which is kind of a popular discussion forum. Often they'll incorporate biomedical text, so they'll often use PubMed Central, which is NIH's repository of scholarly text. But it's essentially training these models to fill in the blank with enormous amounts of essentially data gathered from the internet. There's also models that will generate images. Those are sort of the same general approach. It's just generating images found on the internet from sort of text descriptions of those images. So I think that's kind of in the scope of these kind of modern chatbot models or kind of like DALL-E image generation models. That's how they're working. They're essentially all trying to fill in gaps that we intentionally create as a first step. And these models have existed for a while. And so from the one hand, you could say, well, why did everything change with the release of ChatGPT, right? You just told me these models have existed for a while. They've actually been about as good as ChatGPT was in terms of their ability to fill in the blank. One of the additional things that OpenAI layered on top of it was something that is technically called reinforcement learning with human feedback, which is a very complex way to say. They used it to generate stuff, and they had a bunch of people say, looks good, don't like that. And they essentially trained the model to produce things that look good. And this is this is a bit of an oversimplification, but that's fundamentally how that process works. And if you put those two things together, you get a model that is actually really good at generating what people want to see when they type something into a prompt. But it is, at the end of the day, filling in the blank.
So one more thing I wanted to ask you is, and I think this will be important for our discussion today, is the idea of a black box algorithm. So what is that, and what do we make of that?
Yeah, so I said we were gonna scope AI to kind of these machine learning models. One of the challenges of these models is that as they get large, it becomes very hard to understand sometimes why they say what they say, why they predict what they predict, why they generate what they generate. And so for models where we don't always have a good explanation, we'll often call those a black box model, which means I know what I put in, I know what I got out, I have no idea what happened under the hood. As we think about using these in healthcare, there's a lot of interest in going to models that are much more transparent, so thinking about how I can understand why did this prediction actually come out. That field is growing and moving forward pretty rapidly. But for these extremely large language models, we're still in very early days of understanding of all the plausible text that could have been generated. Why is this, when it had to fill in the blank, why did it fill in this instead of that? That remains a relatively open question. So if we talk about black box models, it's a model where we know what we got out, but we're not 100% sure as to why. And this contrasts with previous systems that used automated reasoning over knowledge bases. So this is the set of stuff I said we wouldn't really cover. Those systems, you sort of have a set of axioms, or potential rules, and you can see how those rules combine to give you the output. So that's kind of, we've somehow made the jump from systems where we can say, okay, this is why we got this, to systems where we're kind of after the fact asking, okay, how did we end up getting that? And it's much more of a research question instead of knowing the answer up front.
And so we kind of jokingly called this panel, will your next doctor be a bot? But let's talk about the more realistic applications for AI in healthcare and what's really coming down the pipe. Yeah.
Okay. Yeah. Well, I should probably throw this to CT, so I'll be brief, and then I'll toss it to CT. We think about AI in both biomedical research, so advancing kind of basic biology, our understanding of systems, as well as how it can be deployed in healthcare. I think a lot of the approaches where AI is getting used now, there's sort of two different flavors. One is relatively simple models that produce outputs that can help guide providers. So I think that is, that's kind of where we're at in terms of supporting medical decision-making often. And then the other part is, strategies that allow providers to spend more time with their patient by letting them use their time more efficiently. And so I think these are sometimes more open to the use of these kind of complex models because they're essentially really helping to empower providers, but if we don't always know how they generated what they generate, that can be okay as long as someone's looking at the output and making sure it's good before it gets passed along to help a patient.
So yeah, CT, you're actually doing some of this work at UC Health. Maybe you can explain what's being used.
Great, thank you. I want to divide my comments into the shiny new object, GPT stuff. I want to talk about that first, and then I want to talk a little bit more about what we have more experience with, which is predictive models. So I'll do that in the second half. In terms of ChatGPT, we have 3 projects with generative AI, the general term for GPT. One is called ambient documentation. So as you may know, we have an epidemic of physicians and nurses burning out from during the pandemic and subsequently. And we have a number of clinicians who have, retired because don't want to do this anymore. It's too burdensome. In my organization, I'm sometimes called the guy who ruined healthcare because as a CMIO, I force everyone to, you got to use the computer, you got to type this. And some of our older senior clinicians who are most experienced, they did not grow up in this age. They are digital immigrants. And so navigating this world is a bit of a challenge. And so we're trying very hard to make ends meet with our senior clinicians who are most experienced. The thing that we're doing with ambient documentation is the idea that instead of, as we do now, a patient and a physician or a provider having a conversation and then at the end of the day when you have 18 notes to write, you sit down and type away, this is what the patient and I talked about, and this is resulting in what we call pajama time. After the clinic is over from 6 o'clock to 9 o'clock, and in some cases up till 1 in the morning, they are finishing their documentation. So one way to do this is to have the AI listen in on the conversation, transcribe it, and then based on word completion go, you've shown me what a progress note looks like. I can reshape that into a progress note. So Bing magically, when you take the 20-minute conversation, whatever it is, it writes a concise summary of that note. And boy, is that hours out of your day or not. We're just getting started, so I don't have any experience to tell you, but the early experience from other healthcare organizations is if you select the group of physicians carefully, you can save doctors hours of documentation. So that's one thing we're looking at. The other thing we're looking at is chart summarization. So as we generate more and more data on patients in hospitals, in clinics, over decades, when you meet a new patient, it can be daunting to open up the chart and go, there's 1,000 progress notes in here. Quick, before you see your next patient, read up on this patient, make sure you're up to date. And can you have the AI overnight, when you know which 18 patients you're going to see tomorrow, generate a summary? Over the last 10 years, the big trends in this patient's care are, and these are the things to pay attention to. The challenge is early on, as we implement these new tools, someone's got to do the cross-checking, right? We know about hallucinations, we know about confabulation, we know about the AI going, well, if I'm trying to please you, so I'm going to complete all these words, and I've heard these sentences before. Let me put some sentences in here, and they're not about this patient. They're just, words that seem like they go together, and then you go, this entire episode of care didn't exist in this patient's chart. How are we going to make sure that doesn't happen? So we have lots of things that we have to work out before we can trust tools like that. But that's the second space we're getting into. The third space we're getting into, I'm going to ask Dr. DeCamp in a minute to comment on because we just started this week, which is a chatbot reply, draft reply, to a patient's incoming message. This is another reason CT Lin ruined healthcare, because in our organization, we encourage our patients to send messages to their clinic, to their doctor, rather than come to, in some cases, you don't have to pick up the phone, sometimes you don't have to come for an entire visit if it's a quick question. And we, before the pandemic started in early 2020, we were receiving at UC Health 53,000 messages a month. Now, that's not bad. We have 4,000 doctors. It's spread among 4,000 doctors. During the pandemic, end of 2020, it spiked to 183,000. That number has sustained every month since then, 190,000 messages a month. And on average, for a primary care clinician, this is 15 to 40 messages at the end of the day after you see the patients, after you finish writing your progress notes. Finally, open up your in-basket, you've got 40 more messages to deal with. So can we take care of some of that burden by saying, you know what, in a quarter of these messages, a third of the messages, which is the experience elsewhere that we hope to replicate, we wrote a draft reply for you. And you can go, if it's an ankle sprain question, it'll write you a perfect ankle sprain treatment course, and you go, great, send it. And sometimes it'll be like, no, I wouldn't say that at all. You want to write something new. So I'm going to ask Dr. Kemp to tell us what he's experienced.
Now that's not on the spot. So I have started using it or reviewing it this week, and I guess I would make just a couple comments so far, which I shared earlier as well, which is one thing I've noticed is that the responses from the chatbot, ChatGPT, or the technology, I guess, are a little bit longer than I would generally say. An example, a patient wrote in telling me that they'd had their colonoscopy. Here's the report, can you fax it to the gastroenterologist? And my response would have been, sure, got it, thanks. And the chatbot said, dear so-and-so, thank you for your important message. I understand that you need us to send your report to a gastroenterologist. We will do so at the earliest possible time. Take care. And so that's one difference, and I found myself wondering, and then I'll let you get back to your presentation. I think a patient of mine who reads that probably starts to wonder, what's wrong with DeCamp today? I hope he's okay. This isn't exactly how he usually communicates with me. And maybe the other thing, and you might comment on this, I have noticed in a more serious way that the technology has a harder time with complex multiple messages. If someone writes in and has multiple issues they'd like to have addressed, it has a much harder time with that.
Thanks. So here we are on day 2 of our test environment, and we're clearly going to evolve over time.
Can I say one more
thing?
Please.
Sorry.
Sorry. The other thing that I've heard people talk about, and you mentioned burnout and well-being, is that the joy physicians and the other clinicians may be getting from reading these messages and laughing at them may actually be offsetting burnout.
That's great. All right, so those are our 3 shiny objects that we are playing with in the ChatGPT large language model space. I do want to talk about, though, our work with predictive analytics, and I think this is pretty powerful. We have a problem with sepsis. So sepsis is a blood infection that once you're diagnosed with it, your mortality rate, your risk of dying is 50%. It's a terrible disease, and it's very hard to spot. And nationally, what the statistic is something like 50 people a day die from sepsis in our hospitals nationwide every hour. Every hour. So it's a big deal, and it's really hard to work on. And so one of our ideas was, can we use years of our data and assemble it and use the learning models, machine learning, to come up with predictions? And so yes, we did that, and also our electronic health record vendor, Epic, also built one. So we actually put several models together and put it in front of the clinicians, and like the movie says, if you build it, they will come, right? So we put these models and then we color-coded them for the highest risk, and we put them in front of the clinicians. So in their list of patients that they see on every floor, or as they're walking around by specialty, you see the bright red ones, and we expected to be able to detect sepsis earlier. Well, as my daughter would say, don't hurt your elbow patting yourself on the back so hard, Dad. And what, as we turned out in a 3-month pilot test, no change in sepsis cases, or time to antibiotics, or time to IV fluids, or the first intervention to try to save patients who are developing blood infections. Really hard to do it. And as we debriefed the nurses and physicians, as we showed them the scores, they go, well, we're 100% busy taking care of patients who are sick right now. It's hard to think about 12 hours from now, someone might get sick. And by the way, your signal to noise is terrible. For every red alert you send us, for example, on a particular nurse unit of 60 patients, we'll get about, or of 30 patients, we'll get about 60 red alerts a day, of which 1 or 2 are real deteriorations, because it's trying to be sensitive. It's trying to go, this one might be one, this might be one. So it's not very specific. It doesn't help you hone in on the one or two that you need to worry about, because we wanted to make sure we didn't miss any. And so the difficulty is that it's too much noise. So that was our failed version 1. Version 2, though, was we ended up putting aside a virtual health center. We now have an entire floor, it's almost an entire building of nurses and physicians whose job it is to look for predictions. And now we have multiple models. We have a fall risk prediction, trying to prevent the next fall, who's at higher risk in the hospital, sepsis predictions, and so forth. And now, because you have no other distractions, you're not running around from patient to patient trying to figure out how to save them right now. All your job is to watch everybody. And we have 1,800 beds in 12 hospitals. And this team of nurses and physicians, that's all they do. So we applied their skill to this, and it turns out when you have a consistent team who can actually be on the spot with these predictive alerts, they sort through the noise, and now in 2011, which is the first year we truly ran this, we saved 200 more lives per year compared to baseline. And we already think we do a reasonable job taking care of patients, 200 fewer sepsis deaths the following year. And then subsequent to that, 800 fewer sepsis deaths this year because we've improved the model over time. So this is where the innovation really occurs. It's not, as I usually say, it's the 80-20 rule. When we put in a new technology like chatbots and like all these new things, 20% of the work is the technology. 80% of the work is making sure the teams come together and use the tools right. It's very hard to do that. When you go around the country, you read the news articles, well, sepsis tool doesn't do much in so-and-so hospital, or if this one flamed out as well. You're just talking about the tool, and what you don't see is the iceberg under the water, which is, did you reinvent the way you care for patients? Did you take the team apart and put it back together in an effective way? And we feel like that's the secret sauce.
Yeah. You told me that sepsis figure, and I was just almost dropped the phone. I was blown away by that. That's incredible.
Yeah. It's a big number.
So, and that really, that was significant for me because it started to change the way that I was thinking about AI in healthcare, because I had been very skeptical, right? I heard like, oh, we're going to bring these new tools. That sounds bad. That sounds scary. Dr. DeCamp, I'm wondering if you can talk about some of this, about you've done research on physician trust of AI tools versus patient trust of AI tools, and what sort of regulations are there actually in place to make sure these things work responsibly?
It's a good question. So I work at the Center for Bioethics and Humanities, and we do multidisciplinary research across all areas of science and medical ethics, and we use methods from the arts to history to philosophy like I do, to the social sciences and beyond. And so we're really interested in concepts like trust and what predicts trust. Maybe I'll start with an example. I could talk about lots of different ethics issues, but I'll start with maybe an example that pulls a couple threads together. So we have a research project funded by the Greene Foundation that's looking at how patients in particular perceive the use of chatbots, patient-facing chatbots in healthcare. These are, imagine you go into your electronic health record on your phone and you can connect to a chatbot associated with your healthcare system and ask that chatbot for advice, with the goal being that perhaps you could ask that chatbot all sorts of questions. You could ask, when's my next appointment? What was my last test result? And beyond, even to the point where these chatbots can help you fill out advanced care planning documents, help with nicotine cessation, and do motivational coaching, and so on. And one of the key ethics challenges that we're interested in is this idea of, in some ways, how much should a chatbot like this be influencing choice? And what are the factors that predict whether a patient, for example, trusts that chatbot in a way that would influence the patient's choice about healthcare, about a decision that the patient might make? One element of it that we're looking at, which isn't true for ChatGPT, but is true for a lot of patient-facing chatbots in healthcare, is a seemingly simple question of, what does the chatbot look like? What's the avatar that one chooses to portray with the chatbot? And it turns out there's emerging research that if this avatar looks a certain way, oftentimes if it mirrors someone's race or gender, the patient on the other end is more likely to rate the experience as positive, more likely to follow the recommendations of the chatbot, and so on. So from an ethics perspective, we ask the question, well, is that wise use of behavioral economics and nudging, or does that cross some line into manipulation, where now we're manipulating someone's emotions or feelings in order to get them to do what we want them to do, which is perhaps get a colonoscopy so that our quality metrics look better. That's an example of a kind of...
also better care for the patient.
And better care. Well,
we want our quality.
we do want the quality metrics. So those are the kinds of issues that we're interested in. And maybe one other issue that I want to make sure is on the table, and I think it connects some of this conversation as well, is the issue of bias. You can't avoid the issue of bias in AI. It's all over the news. It's a really important and useful topic. Going back to what Casey was discussing, it turns out it really matters what texts we use to train. And if all of our texts are English language from the internet in a particular format, that creates a bias in the training. To the extent that we use human beings as part of the analysis to reinforce the learning, if those human beings have biases, that can create another bias, where at the end of the day, what happens is we have differential performance of the AI for different groups of people. And often when those align or assort according to race, ethnicity, gender, and so on, again, from an ethics, fairness, justice perspective, we get really worked up about that. So understanding whether algorithms in healthcare, when I'm at the bedside with a patient, whether the algorithm is as likely to make an accurate prediction for this patient versus that patient, turns out to be a real concern and something that I would be likely to ask CT about.
Thanks. I mean, to your point, this is not an AI example, but recently coming to light that those pulse oximeters that we've attached to everybody to look at the oxygen, turns out your skin color is different, it doesn't perform the same way. Oh, like that's just something we're discovering now because we were all biased thinking, well, we already did the study, it worked great. And we presume that it performs well for other people in diverse situations, and that's a terrible assumption. So that's hidden bias that's very hard to get at. And your next question is going to make me squirm because it's very hard to avoid bias in AI systems, especially since they are black boxes. You can't go open up the hood, lift up the hood and go, oh, there it is, let's take that one out. It's here's the 12 people you should go look for who are high risk for sepsis. And you go, okay, I'll trust it and go run and see those patients, rather than, are you sure we're not missing an African American in here? Or are you sure we're not missing an Asian in here? They're all Caucasians, or most of them are Caucasian. So we don't know until we dive back into the data and really look at it. We have to have a discipline and maybe hire 30 or 40 Matts over here to try to really think about this in a sophisticated way.
Well, so that was going to be my question, is how do you assess that? How do you make sure that you're not leaving somebody out? If
Very carefully. No, we don't know. I mean, this is a brand new field to think about. We don't know. Yeah.
You know, there is movement. You know, one of the realities, I'll put on my philosophy hat for a moment, one of the realities is that human beings have, for hundreds or thousands of years, long disagreed about what counts as fair. What is fair? And so we shouldn't expect AI to solve this debate, and it probably won't solve the debate. That said, there are movements. I think you had asked earlier about regulations, and there is movement to think about at least how to make the fairness assumptions and the trade-offs that are being made more transparent. We see this in some journal reporting guidelines for if you're reporting an AI clinical trial or clinical study. Now it may be required that you assess your model's performance under different assumptions to see if different subgroups benefit or not. It's not a big part of the FDA regulations. That's not surprising. FDA has not typically regulated fairness, so to speak. It's more about overall efficacy and safety. But many people have tried to push the FDA to say, look, when a new tool comes forward and you're going to regulate this AI algorithm as a device or software as a medical device, why not put as one of the requirements that you've evaluated according to different assumptions, again, about biases and fairness, so that people understand the trade-offs that are made when we're doing these models. Keeping in mind, by the way, not to add another big picture, keeping in mind that healthcare and medical care is already biased. And so in some ways, we're also oftentimes saying, well, there's biases in AI, but guess what? There are biases in healthcare right now that we all know of. And now we're actually trying to figure out, well, which biases are worse or which ones are better, and how do we think through that? So I think there's movement to try to make biases more transparent, at least.
Matt, if I can ask you just one more quick question while you have the mic. So you mentioned earlier about your experience using the automated reply to patient emails and it coming across as kind of stilted, wordy. And you thought that patients might think, if they thought that was written by you, that you were a little bit cracked, but what if they intuit that it's actually written by AI? How do they end up feeling about that?
Well, one of the nice parts, I think, about the way it's been implemented, and I was supportive of this, is that for the sake of transparency, the message includes a note at the bottom that says it was partly generated by AI. And that, I think, right now is a really important part of transparency, so that patients are aware, even if I've edited it, that in part some of that message was written by AI. And that's really important to me, and I think that's important from an ethics perspective, even though I can see the other side, right, which is, well, technically, DeCamp, once you brought it in and once you edited it, it became yours, and you take responsibility for it. I can understand that to some extent, but I think transparency for me is just really important, at least at this stage of AI.
Yeah. I mean, to me, it's fascinating to think about going through the pandemic and the challenges that we had with trust and some of the ways that trust was frayed a little bit for some patients. And what does this end up now adding this onto it? What does that end up doing with patient trust? And we've seen the way in which patients trusting their doctor is a really big deal for public health. It's one thing to correctly diagnose a patient and correctly prescribe a course of treatment, but the patient's got to do it. And if they don't do it, that's basically a loss.
Well, and it's an interesting, if you go back to this avatar situation and the chatbots, that's what we've heard from patients. We were interviewing and surveying patients about their experience, and it's not surprising to me that we do hear from patients that they wish the language the chatbot were using were a little more close to their language. It sounds kind of academic. It doesn't understand vernacular. When you present the chatbot with vernacular, it doesn't understand it very well. It doesn't look like me. Why does the hair look a certain way? Why not make the hair look a little bit more like me? Why can't I pick my own avatar for the chatbot so that I can use it and have it resonate with me better? So I'm not, with what you said, I'm not surprised that we hear things like that from patients.
Yeah. So, Casey, I wanted to ask you a question. We had been talking when we were chatting just before the panel about the ways in which chatbots could potentially be beneficial in mental health care, and some of the work around actually trying to set up a mental health chat bot for people who either feel more comfortable not talking to a real person about their issues, or who, given the shortages that we have in mental health care providers, just can't get into it.
Yeah, so I think, this goes to, I think, also both what, Matt and CT have been talking about. I think there's a lot of different ways that these tools and technologies could be quite beneficial. And I think, sometimes it may actually be easier to have a conversation with, not with something is not a person, to share information. And so I think there's, a potential path where patients might be able to share a more full story with, knowing they're talking to a chatbot. And, I think another way that that these tools can be potentially beneficial. A set of researchers did a study where they took a bunch of patient questions from Reddit as well as clinician answers, and found, and then they used a chatbot to also generate hypothetical responses. And they ended up finding that the chatbot was rated as empathetic about 10 times as often as the physicians were rated as empathetic. And, I think, one way to see this is, well, physicians aren't empathetic anymore, right? But I don't think that's true, right? I think it's just, When you don't have that same time constraint, there's a lot more opportunity to kind of communicate clearly, really show that you were listening. And I think these are ways where, we can actually, there's a real opportunity to improve care by kind of almost improving communication. And I think that's, while I agree, we probably it needs to sound a little bit more like Matt. Maybe it needs to sound like Matt with a lot of free time and really. I don't know. I guess that's where I would come down on it. I think there's going to be a lot of opportunity. I also agree we have to be really careful about how we use and deploy these, how we think about biases in them, and ideally really use these as an opportunity to study healthcare, to study biases, and try to make sure that this minimizes instead of exacerbates biases. I talk a lot about this idea of bias laundering, which is the idea of taking biased practices, feeding them through machine learning models, and then assuming that your end model is unbiased. And I think that's really dangerous, and I think now widely recognized, fortunately. So yeah, I think we have to be really thoughtful. We have to consider how this is going to impact people. But there are, I believe, a lot of opportunities here for this to improve our health as a society.
I might follow up, and this puts a little more onus on you, I think, CT. In a different study we have, it's looking at the use of AI-based prognostication models, so the use of AI to predict mortality, time of death, certainty of death, and so on. And despite what you just said, Casey, when we talk to clinicians, both physicians, nurse practitioners, and others, they seem aware of the bias problem in general in AI and not aware of the potential for bias in these prognostic models. And it comes back to you, CT, because one reason is they simply assume, well, if my health system is employing this model and launching this model in our electronic health record, then there's no possible way it could be biased. So the clinicians are putting a lot of trust in people like you to make sure that a model is unbiased before launch.
Thanks, Matt. The good news is we're not going to be out of a job for a long time. There's lots to do in this space. This is a shiny new object. It's a brand new environment to play in or to study, and we are constantly finding new potholes to step in. There's a great book that's called The Glass Cage. It's a book about the aircraft industry and the vaunted glass cockpit that Airbus and Boeing put out to make it much simpler for their pilots to learn to fly and to manage the plane in flight, because the 1,000 manual dials that took years to learn are now 6 beautiful iPad displays that on takeoff it looks this way, during flight it looks that way, and during descent it looks a different way. And now, that's supposedly the cool thing. The downside is everything is under glass. It's anesthetized. You can't feel anything. You move things around, it's touching glass. Things are dangerous, you're touching glass. It's all the same. And I took this personally as an attack on my entire career, which is we're putting patients and their data under glass. Now you have a mouse and keyboard to interact with all these data points that you used to be able to smell and taste and get a sense of. You stand in the doorway and you look at the patient, and one of my attending trainee, as I was in training, I used to have him, he used to stand me in the doorway and go, is this patient sick or not sick? And you got really good at standing in the doorway and going, this patient's sick. And you get a sense of it from the nonverbals. Well, sorry, CT Lens removed all that. It's all under glass. And so the concept, I'm going to get to my point in a second. The point is there's a concept called automation complacency, which I took very personally, because the idea that as we develop more and more predictive tools, our clinicians step back and overly trust the engine. And so I actually had a physician call me and complain. Your thing misled me. I'm like, well, what are you talking about? He says, I put in a muscle relaxant medication for my patient, and this patient was taking birth control. Turns out birth control failed because it was a drug interaction between the muscle relaxer and the birth control, and your system didn't stop me. Oh, wait a minute. We've been removing drug interaction alerts because all of you are complaining there are too many pop-ups, So sure, let's only leave the most critical ones, and this moderate level pop-up about birth control and we took it away. Well, you should have been there to stop me to do that. So now you're giving away some of your own expertise at how drugs work and giving it to the computer and saying, let's just put it in and see if it complains. Oh, it didn't complain, must be okay. And I think this is writ large what we have to worry about with AI is that we put it in and we go, well, it's good over here, it must be good at all these other things. And assuming that, so this automation complacency, I think is sort of the next level of anxiety that I'm going to carry forward in terms of figuring out what to do next.
Oh, that's fascinating.
Yeah.
So that makes me think of something that we had talked about when we did our panel pre-call, which is you kept talking about things that AI could do, and you're like, well, if we could train AI to do something as a smart medical student would do it. And it was like documentation as a smart medical student, chart summarization as a smart medical student, and it made me really think like, okay, so what are the smart medical students going to do? Like, how does this change the way we need to be training doctors?
Yes. In years past, and I think I'm probably one of the last to do this, you would go to school and you would get in-depth training to go to college, go to a trade school or professional school like medical school, and then you would find an organization and you would stay there for your 50-year whatever career, and you would retire from that organization. I've only moved once from UC Davis to here. But I imagine, given the technological acceleration and the idea that your job is not going to be the same in 3 to 5 years, we think now training the current generation of college graduates, congratulations, here's your starter job. It's going to last about 3 years until it's completely different. And then you got to apply for your next job. Are you going to keep up? Is I think the idea. And to your point, what are students doing now? They're being introduced to the AI models now. The best students are incorporating knowledge learning into like, what's they good at, what am I good at, how am I changing my job next? And it's not a static sort of, here's your job for the next 50 years. It's how are you going to keep up with what's changing in the field you choose to study?
Yeah, Matt.
I'm going to make a comment and then a question for Casey, which is one of the things I've heard about medical education and related to ChatGPT and chatbots is that it's really important to teach people how to ask the right questions or how to ask questions in the right way to ChatGPT, because it often gives different answers even if it's the same meaning of a question, but if the question is asked differently, it responds differently. So we have to train people to ask the right question. Can you comment on why is that? And is it possible?
Yeah, so that does happen. It is based on kind of the fill-in-the-blank nature of these models, that sort of you have a tiny difference in the initial starting conditions. You can end up with a big difference in the output. It's actually created a job. So there's a job now called prompt engineer. Has anyone heard of prompt engineering? Okay, we've got some prompt engineering experts in the audience. So the job of a prompt engineer compensates similar to or slightly above what software engineers get paid. You learn how to ask questions in a way that people can get what they want from these chatbots. That is the job, which I think is pretty remarkable. And that goes to your point of, even minor differences in how you ask the question can dramatically change the value of the responses. I think some of this is probably here to stay. I think other parts of it will probably get better at sort of designing systems that generate similar consistent results for similarly consistent questions, but it's going to be, that's probably years of research to get to that point, right? Because it's going to require kind of better reasoning about the underlying meaning of the question. I do think at some point the systems that people built and kind of threw away in the 80s into the 90s that were based on sort of the idea that there are some fundamental reality that things are based in, where you can reason in that reality, and we can build AI systems through reasoning. We've kind of thrown all that away, but I think some of that might start coming back and being hybridized with these machine learning models that are largely fill-in-the-blank based systems, because what those systems could do is, if you ask a question that is logically equivalent, you get a logically equivalent answer. And so I think we need to, at the moment you have described the state of the world in this area, but I think some of the research that's happening at CU as well as other places has the potential to begin to start to hybridize these again and get us to a system where what we think of in terms of semantic meaning kind of lines up with how the systems are actually generating output.
So I wanted to throw one question here to our panelists before we get to audience questions. And that's about, we'll call it the darker side of the potential use of these kind of tools. We've been talking about their use in patient care and trying to maximize the quality of patient care, trying to make it as good as it can possibly be. And so the failings in this area would be failings to achieve your goal, but there's also another potential use. And Matt, I heard your colleague Matt Winia, who's also a bioethicist at CU Anschutz, he mentioned this in another forum about the potential that these tools could be used in ways that enhance a healthcare company's bottom line. That are being used to, maybe cut off, if you're an insurance company, you want to figure out how early can I cut off support for payment services for paying for medical services for this patient. If you're a hospital, you could, I don't know, potentially could you be using these tools to figure out how early you can discharge a patient? So that's sort of the other side of the concern that I guess I would have around these, and I'm wondering what your thoughts are to start.
It's a big question. It's no doubt true that insurers, as we know from some things that have been published, are ahead and are already doing and using AI algorithms in this way. Some of the regulations that we hinted at earlier and what's been hinted at in Colorado in life insurance, but in other places, even at the national level or in the European Union, there are movements to have regulations around how algorithms are used. I would say from my standpoint as a bioethics, medical ethics person, in some ways it reminds me of the fact that at the end of the day, we do rely on human beings to make choices about which algorithms are used or developed and how they're deployed. And it makes education and teaching around ethics concepts in some ways more important because it's always possible that these tools, as we might say, although I think if there's time, I don't think they're exactly tools, but tools, as we might say, could be used for those purposes as well. I don't know if you, CT, in your experience.
Is my concern here overblown?
Nope. I think there are some zero-sum games that are going to be played and are probably playing out now. One of the things that one of my colleagues got very excited about, which I told him, that's a zero-sum game. He was like, I can have an AI write a more convincing insurance appeal letter. I said, yeah, you think the insurance company isn't having an AI going, I'm going to sort through those much faster because I have an AI saying, that's an AI written thing, I'm going to throw it out. Because, you can do that now. If you watched Sundar Pichai, the CEO of Google, one of his big announcements a couple of months ago was our new AI can help you get your money back from the airline. Watch this. Write me an airline excuse letter for why I couldn't make the flight. And it wrote this beautiful thing, make it more convincing. And it wrote like twice as much. And you're like, astounding. But boy, we could misuse that in so many ways. On the other hand, we are improving our AI detection tools. And I know of what college professors who are now throwing out student essays because there's a hint of AI in here. May or may not be true. But so I think that ends up being a zero-sum game. Whose AI is slightly smarter than whose? At the same time, there are other unintentional things. We talked about bias. I am aware of a hospital in the East Coast that looked at potential no-show patients and then filling in extra slots for those patients we think will no-show. And it turns out the vast majority of patients who no-show come from lower socioeconomic zip codes. And so every time, basically every African American who comes to this particular hospital, there's a double booking for another patient in that spot. And boy, what kind of bias is that? The AI is just going after statistics, but in that environment, the bias is baked in to the previous statistic. So these are all things that we have to watch out for.
And Casey, I'll pose this question to you in a little bit different way because when we talked on the phone, we talked about kind of the Target example, the idea that Target knows you're pregnant before your family knows you're pregnant because Target can study your purchasing patterns and knows what you're buying there and knows that when something has probably happened. And so it's this idea should we've been talking about how AI using your healthcare data, but there's potentially ways to spot healthcare issues by using consumer data or other kinds of data, and should AI be doing that? And my initial instinct was like, hell no, and then I thought about it, and I was like, well, if AI knows something about my health, like, it should tell me that. That's kind of crap.
Yeah, I mean, this is a tough one. So, one of the earliest, for folks who are beginning to experience dementia, one of the earliest organizations that would probably be in a position to know that is their bank. Not their healthcare system, but their bank. Because, there are changes in patterns for folks who've never missed a payment, who start, miss 1 or 2 payments. And it's not much, but it's enough to start to give a hint. To my knowledge at the moment, there's, that type of data sharing doesn't happen. But you could imagine benefits and drawbacks to this being shared. So I have kind of a similar reaction to what you do. Like, why should these organizations predict anything about my health, right? It's not really relevant to their business. On the other hand, if there are ways for people to get the care they need or be protected against fraud, because this is, something that an organization like that has been able to predict, I don't know, it's a tough, none of these have easy answers, right? That's why we have Matt here. I think it's easy to see the potential for benefit. It's easy to see the potential for harm. I think this happens anytime you have a powerful technology. I think it's important to be thoughtful and to have an environment where we consider what regulations are necessary to have these technologies have the benefits without being subject to the potential drawbacks. I think that is ultimately the role of regulation.
Well, let's open it up to audience questions. I think my friend Lance will be, or do you just want me to call on folks? Okay. So we don't have a microphone, so speak up, and then I'll for the recording, I'll repeat your question. So let's go right here.
Okay, my name is Maureen Welch, and I have an organization called Navigating Disability Colorado, and I've been getting involved with a group of independent mental health providers, and they've kind of come together to share information. And one of them read the entire agreement with a company called Simple Therapy, which is like a online therapy tool that therapists use. And in the small print, it said that they will be monitoring the therapy sessions for ChatGPT, and that practitioner has to agree to it. So I'm wondering, from consent, do those patients know that when they are, is that in their fine print? It's very concerning, and some of the practitioners are saying, I'm not going to use that integrated tool or whatever you want to call it. But I have a question about consent and ethics around where is the data coming from for all of this? Because apparently they want to develop better understanding of what goes on in the therapy session. Well, I don't want to be in that session if they're doing that. So anyway, it's something that was a real red flag to the independent mental health providers that use a lot of the telehealth. There's a gazillion of them. I didn't realize that until I got involved with them.
Okay. Yeah, so this is a really good question about consent and about whether patients can consent to having their health data used to train AI.
And also practitioners,
Yeah.
They're both in there, yeah.
Okay.
It's a great question, and I'm sure both of you have thoughts on this too. On the one hand, it reveals very clearly, like we've always known, that no one reads the fine print. Right? When I was on an institutional review board, we reviewed research. Researchers often wanted to use apps. If one of those app studies came through, the first thing I did as a reviewer, as an ethics reviewer, was go read the fine print to determine what the data use was going to be beyond the research study. And so people don't read the fine print, and in ethics we try to find ways to tailor messaging and make sure that important message about consent gets through. The other thing I would say about it, though, is we also, even from an ethics perspective, try to constrain how much importance we place on consent. In other words, it's to say that you can't simply consent your way out of every risk. It's not managing a risk simply to tell people about it. And so in some cases, when it comes to privacy and confidentiality and data management, there is more of a push on institutions to be proactive in privacy management and data management practices because of that fact that you can't consent your way out of every risk. As for the real world of data sharing and what can and can't,
In our early days with AI, we are explicitly asking the patient's permission. Well, with chatbot, we're being transparent that this was drafted by, I think the word is, this was automatically generated and then edited by doctor, and then the name of your doctor. So that's at the bottom of every reply. When we get to ambient documentation, when the clinician takes their smartphone out for that recording, they'll say, would you be okay with me recording this conversation because it will help me write the note later? And if you say no, then we put it away. And so right now it's permission-based for many of the tools that we're working on. At what point will it become sort of accepted practice and we won't ask anymore? It'll be part of the 5-page consent that you sign. I don't know the answer to that. But right now it is very opt-in.
Yeah.
So I'm wondering what the effect of kind of legal system and management and so on giving the best care will be. You know, I see in the auto industry we have self-driving cars. I think it is actually finally gotten to the point where, on average, they're safer than human drivers, but there are still lots of horror stories about in press coverage of the rare accidents and so on. In the health realm, what non-health related roadblocks will there be to appropriate use of appropriate technology that is less biased or less what roadblocks do you see?
One easy answer is that if the FDA gets involved in all of the AI development, the rapid cycle development of the AIs that we're playing with now, I can imagine an 18-month delay every time you have a version and you'd submit to the FDA and go, I wonder if they're going to be okay with this one. And they're going to ask us, well, how many environments did you test this in? Did you test this in XYZ zip code? And we're like, all right, we'll go back and do that. And so I could see the pace of innovation dropping off the face of the cliff if that's the case. So where's the right answer? And I don't know what the answer is.
It's not clear whether they will or not.
It's under active development right now. Is the FDA saying that the AI is a new device, and we regulate devices? So where's the battle going to end up? The answer is we don't know yet.
I think the other barrier, and you hinted at this earlier, the other barrier to AI use and adoption is going to be a lot of human factors. It's going to be people's comfort level with technology, which we know is sorts according to all sorts of characteristics. People's trust in technology, digital literacy varies. There are going to be some clinicians who use it right away, early adopters. There are going to be late adopters. So there are going to be a whole host of human design factors that will also potentially hinder or make inequitable the use of the technology.
We do know that, for example, the sepsis program was impaired by nurses who were so far behind in their charting that they would write vital signs down on the back of their arms, and then all the alerts would go off at end of shift, because that's when they put all the vital signs in. Bing, 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 all these things are going off. We're like, well, it's 12 hours later, it's too late. So.
Gentleman in the front.
Yeah, a question about, in the future, do you see a possibility where I could just type in or call in to a central location and say, these are my symptoms, and tell me which doc I should see?
Yeah, I'll repeat it again. Sorry, I forgot to do that for the last one. So this is about whether you can get an AI diagnosis, kind of like a pre-diagnosis, a very sophisticated WebMD kind of thing.
I think you can answer this in several different ways, depending on whether you're an AI aficionado or someone who's thinking the dark side is coming for us. In an optimistic viewpoint, I think not very difficult, not very far out, could we have you say, which specialist should I see? And we could train it with characteristics and diagnoses of, so you're not having to search for 1,000 doctors. You can go, well, here's a handful that seem to match what your profile looks like. So I could see that happening pretty soon, to the point of saying, well, give me your symptoms, and then I'm going to coach you through, should you go to the emergency room or stay home? I think that's a bit trickier to get to that, and certainly the FDA will step in and go, you can't put that out until we approve it. And so there's lots of socio-political barriers to get to where we want to go, but I think that's on the horizon at some point.
I think we have time for one more. Did I see one over here somewhere? Yes, sir.
Hi, I'm Tom Cosgrove. I am a nonprofit political strategist.
Yes, just a question about coming regulation and making sure that your tools are people-centered.
Yes. That's an excellent question, and it's unanswerable with what little we know so far. We will adapt to whatever future circumstances there are. If the FDA is an 18-month cycle to the next version of the software you're going to write, we're going to write 17 different things and throw it at the FDA. And how many thousands of people will the FDA need to hire to keep up with that level of innovation? This is an unknown world, right? So don't know. And it's an excellent point that we do need to keep our patients at the center of what we do. And that's crucial. And sometimes some of our partner health systems don't necessarily have that front and center, but that's crucial to all this work, absolutely.
So the FDA could use AI.
Sure, can we trust that one?
Thank you. Well, so we have a real treat here. Dr. Lin has offered to play us a song for us, to play us out, and I'm really looking forward to this. You can explain more if you like.
So I'll explain this as this is one of the songs that when we went live on Epic in 2011, our health system had, as you might imagine, right, the only person who likes change is a baby with a wet diaper. So none of our doctors are babies with diapers, and no one's happy with having to transition from paper records to electronic records, and the guy who ruined healthcare would play them this song. This has a stanza in it on predictive analytics, so I thought I would play it for you. Let's just do it this way. There is a hospital in Colorado. They call the rising sun, and it's been the ruin of many a poor doc. And God, I know I'm one. For the only thing that a doctor needs is a paper sheet and a pen to write a prescription. Hard to read, an error on its way he sends. Computer screens replacing those old charts. The floor swarmed with eager red shirts. No place for us old farts. At first we had a tough old time. Pandemic fever on the rise. We were not so sure that we would survive with keyboards and mice to sanitize. Oh, mother, tell your children not to do what I have done. I've ignored those alerts and reminders in the hospital of the rising sun. But then something changed in the air one night. Those sepsis cases, we had none. With predictive alerts and surveillance teams in the hospital of the rising sun. Oh, I got one foot in my deep, dark past and one foot in the car. I'm going back to Colorado to be an epic star. Oh, there is a hospital in Colorado. They call the rising sun, and it's been the savior of many a poor doc. And God, I know I'm one.
That was so awesome. Thank you. Yeah, thank you to you. Thank you for being here. Thank you for Sunfest and for being a part of this. Thank you to our panelists. Really appreciate all your insight and your knowledge and just your thoughtfulness here and willing to engage in these issues. And I'd be remiss if we didn't thank our sponsors. Our presenting sponsor is Excel Energy. We have our institution sponsor, which is this campus, the Auraria Higher Education Center, and our champion sponsor is Otten Johnson. So thank you to all of them, thank you to all of you, and appreciate you supporting local journalism.